Hey guys, Yulia back here with another episode of Nerdy NP Car Chat. And today, as promised, we're going to be diving into loop diuretics. And so first we'll start off by talking about the mechanism of where and how they work. And to get a deeper understanding of that, we first have to take a look at what we call the nephron, which is a filtering component of the kidney. So then the kidney contains millions and millions of nephrons, and each nephron has a few different components that I'm going to describe now. And I have this little diagram here that I drew that will help you guys understand it a little bit in more detail. So over here we have something called a glomerulus. So first of all, we have an afferent and efferent arteriole. So the efferent supplies blood to the kidney. Afferent supplies blood to the kidney and efferent takes blood away. Now, as it enters the glomerulus, it's like a collection of different arteries and vasculature that has a really high blood pressure, and that hydrostatic pressure is what pushes solutes and water into this Bumex capsule here, which is surrounding the glomerulus. And that is going to be the beginning of what we call our filtrate, which will then later become our urine. But only small solutes and water can get into the filtrate through the little capillaries in Bumex capsule. It cannot let big molecules through. So big molecules will go back out of the efferent arteriole and then go back into the bloodstream. But the small molecules will get pushed out of the glomerulus through the little capillaries and the hydrostatic pressure that it exerts, and filter into the Bumex capsule and then become part of the filtrate, which will then later become the urine. So then it will move down to the proximal convoluted tubule, where more water glucose will be reabsorbed. And then it will move down the descending loop, or this is the beginning of the loop of Henle. And this is where loop diuretics will work. And that's why they're called loop diuretics, because of the loop of Henle. So we have the descending segment, which is only permeable to water. And we have the ascending segment, or the thicker segment, that is only permeable to solutes and impermeable to water. So we have a co-transporter molecule over here. It is a pump that pumps sodium, chloride, and potassium ions into what we call this interstitial space. So it's a space between the nephron tubule, the kidney, and the bloodstream. So this area here is called the interstitial space, and as the electrolytes, as these solutes get pumped out into the interstitial space, that makes this space really concentrated. And so what happens is water leaves the descending loop of Henle and flows into the bloodstream, and that's how it gets reabsorbed. Meanwhile, over here, you have solutes that are leaving the ascending loop, and they're getting reabsorbed into the bloodstream this way. So this is losing water and becoming really concentrated down here. So this area of the loop is the most concentrated, and then it gets less concentrated as it moves up into the distal convoluted tubule and then the collecting ducts. And so this system is called the countercurrent multiplier system. And the reason why it's called that is because the blood moves in the opposite direction of the filtrate. So the filtrate moves this way and the blood moves this way. And the concentration of water, so water leaving and solutes being pumped out to make this area more concentrated, and then water following to dilute this area, that is the multiplier system. So this is how the kidney filters or concentrates, better yet, this is how the kidney concentrates your urine. And so because most of the water and solutes are actually reabsorbed into your bloodstream, very little water gets, excreted in your urine. And that's what makes your urine concentrated. And that's what allows your kidney to do that, is this counter current multiplier system. So now that we understand that, we have to kind of figure out, where do loop diuretics fit into all of this? And so the loop diuretics work on this transporter molecule here that is pumping the solutes, the potassium, the chloride, the sodium out into the blood. And the loop diuretic essentially blocks this. So this is no longer functioning. And so it messes up the entire concentration gradient. So now solutes aren't being pumped into the interstitial space, and that is ruining the concentration gradient. So now water, instead of being pumped out or passing through, through osmosis into the interstitial space to dilute this higher concentration of solutes, it's no longer doing that, because that concentration gradient is now gone, because this pump is blocked by the loop diuretic, the furosemide or Bumex or Torsemide or whatever the patient is on. And so what happens is, instead of it going back into the blood, it actually just stays in the filtrate, and as well as the solutes and the water both stay in the filtrate or the urine, and eventually they will go and be flow into the distal convoluted tubule, and then they will flow down into the collecting ducts, and then out of your kidney into your ureters, and then down into your bladder, and then out through your urethra. So that's how loop diuretics work. So they block this transporter, and they prevent you from reabsorbing your solutes and your water, and instead that all is excreted in the urine. And so the reason why we often end up having things like hypokalemia, hyponatremia, hypochloremia, all those low levels of electrolytes, is because those solutes, instead of being pumped back into the bloodstream like they normally would, that co-transporter is blocked by the furosemide or the Lasix or Bumex, whatever they're on, and everything is going in the urine, and so you're ending up with very low electrolyte levels. And so this is very important when you're admitting a patient and they have very low electrolytes, and you're wondering, well, why is that? Look at their medication list. Are they on a loop diuretic or other types of diuretics, potassium sparing, thiazide diuretics, which we'll discuss in a later chapter on hypertension. They're not really relevant to heart failure. And so it's very important, if they're very hypokalemic or very hyponatremic, they can end up with altered mental status, altered consciousness, because we know that sodium is very important for that. And they can actually end up in a coma. And with potassium, obviously, that's very important for cardiac regulation, and it can cause deadly arrhythmias, VTAC, cardiac arrest, and death. So we have to be very cautious about these diuretics and watching those electrolytes. Additionally, you have things like hypovolemia, dehydration that can be a result of these loop diuretics. And so we have to monitor this, especially in older adults, because as you know, older adults tend to have what we call orthostasis. Their body, their auto regulation is just not where it should be. As you get older, your autonomic nervous system is not able to auto-regulate as quickly. And so when they stand up, their vessels don't constrict like you and I. And so they actually tend to drop their blood pressure, and they end up falling, and they can break something and end up in the hospital. So we want to be sure, especially with older adults, one, they don't drink much water because their thirst mechanism is not that strong. Their thirst center is not really telling them, hey, drink more water. And two, they're on all these medications. Some of this is polypharmacy, right? They're on diuretics, but then they're also on other antihypertensives, and then they're on some sleep medications, and then they're on things for their urination, their Flomax, for their BPH. And all of those things can affect their mental status, can affect their blood pressure, can make them more orthostatic, and make them more at risk for falls. So polypharmacy is a really big problem in older adults. So especially if you have a patient like that who's on a lot of other medications, you have to do a really in-depth reconciliation and figure out, can we take something out? Can we reduce their medications? And then finally, with this loop diuretic, the one thing I want to say is, so it's contraindicated in patients with what we call hepatic encephalopathy. So people with liver cirrhosis, liver disease, chronic liver disease, they have really high levels of ammonia. Their kidneys aren't able to excrete it. Their liver is not able to excrete it. They're not functioning well. And so when you have hypovolemia, you have hypoperfusion of your liver, let's say from loop diuretics, that further impairs their ability to excrete this ammonia product. And so the ammonia level builds up and they can get more confused and more altered. And we call that encephalopathic. So that means that they're just cognitively impaired. They're not, they may be confused. They may be trying to rip things out, IV lines, trying to get out of bed. And so loop diuretics can exacerbate that. Additionally, hypokalemia and hyponatremia has also known in itself to exacerbate hepatic encephalopathy. So we want to avoid loop diuretics in patients with severe liver disease that have a history of hepatic encephalopathy or just have really poor liver function, end-stage liver disease, cancer, cirrhosis, anything of that sort. So I believe that covers loop diuretics. Finally, so the reason why we use these in heart failure is, if you can imagine, you're in a hypervolemic state, you're really fluid overloaded. Sometimes you have left-sided heart failure, you end up with, that pulmonary edema, the crackles in the lungs, the orthopnea, the dyspnea. So getting that fluid off will help with those symptoms. A lot of people have lower extremity edema, JVD. They might have congestion in the liver, hepatomegaly from backup of, blood from the right side into the circulation, into the periphery, into the abdomen. And so to reduce those things like hepatic congestion, abdominal bloating, fullness, orthopnea, dyspnea, all those things, we use loop diuretics. And then it also helps with lower extremity edema. And then finally, decreasing your blood pressure, decreasing your preload also reduces oxygen demands, and that helps with heart failure symptoms, because if you have a lot of fluid on board, you have a really high preload, that is causing your heart muscle to have to stretch more and exert more force to pump blood out. So the more volume it has, the more oxygen and energy it needs to use in order to accomplish forceful contraction. So by lowering this preload, we're lowering the amount that the heart needs to stretch and contract. And so having less of that decreases the amount of oxygen that the heart needs to use, decreasing oxygen demands, which improves heart failure symptoms. So that's essentially loop diuretics for you. I hope you enjoyed this chat, and I hope to see you on the next one. We're going to discuss vasodilators, nitrates, hydralazine, things like isosorbide, and I hope you join me, and I can't wait for the next episode.